Cerebrovascular disorders. Cerebrovascular disorders can affect a person's lifestyle, or they may have life-changing or even life-threatening issues. This could include headaches. We call headaches cephalgia. It is head pain, so cephalgia. There's a couple of different headaches that we're going to discuss here, and that includes tension headaches. This occurs when a person contracts the neck and facial muscles for a prolonged period of time, creating those tensed muscles. They sensitize nociceptors, or those pain-relaying nerves that are in the head, and they transmit neurochemicals to the brain, which registers the presence and location of the discomfort. And then migraine headaches, which are recurrent headaches. They can be very severe, they can last for longer than a day, and they do have a vascular origin. With migraine headaches, there's 3 sequential contributing factors. We have a change in the serotonin receptors that promotes dilation of the cerebral blood vessels and pain intensification from neurochemicals that are released from the trigeminal nerve. We have fluctuations in reproductive hormones and chemicals in certain foods or a food-related allergy. In addition, drugs can also trigger migraines. There are cluster headaches, which are a variant of migraine headaches. These are episodic. They recur every 6 to 8 weeks, with only brief periods of recovery between a multiple daily attack. The cause of these cluster headaches is unknown, but it can be triggered by vasodilating agents, such as nitroglycerin or histamine, alcoholic beverages, and acetylcholine. Acetylcholine is that parasympathetic neurotransmitter that may possibly play that role in cluster headaches. Clients that do have cluster headaches may also have a slower than normal serotonin level. So these clients may respond to serotonin enhancing drugs. So with headaches, pain can be severe to debilitating. Tension headaches, the pain is pressure or a steady constriction on both sides of the head. With classic migraines, these clients often experience an aura prior to the headache starting, such as flashing lights, or they have a prodromal period before the headache that is marked by a change in their mood, or they have difficulty concentrating, unusual fatigue, throbbing, or bursting pain. With the headache, they can have nausea, vomiting, vertigo, sensitivity to light, and irritability. And with a cluster headache, the pain is usually just on one side of the head, usually behind the eye, and there's usually some nasal congestion, rhinorrhea. There may be also tearing or redness of the eye. To help diagnose these issues, we can do a CT scan, a brain scan, and head and neck x-rays. An angiography might be done to rule out any neurological disorders. So to treat these with a tension headache, we relieve those with rest, mild analgesics, and stress management techniques. For severe recurrent tension headaches, these clients may require counseling and psychotherapy to help them deal with emotional stressors, and we may also prescribe antidepressants. With the migraine headaches, we usually use drug therapy, such as mild analgesics. We can also use ergoalkaloids. These are medications that are indicated for the treatment and prevention of migraines. They actually constrict blood vessels in the brain. So they are contraindicated with hypertension, cerebral, cardiac, peripheral vascular disease, dysrhythmias, glaucoma, coronary or ischemic heart disease. Their side effects include nausea, vomiting, a rebound headache. In other words, when you stop taking it, you get a headache. Dizziness, numbness, cold or clammy hands and feet, and muscle pain. Drugs are going to include DHE45 and the ergotamine tartrate with caffeine. Another medication that we might give for migraine headaches would be your serotonin reuptake antagonists. These will interrupt migraines that have already developed. We give it orally, we can give it intranasally, or even subcutaneously injected. It is contraindicated, as always, with a drug allergy or serious cardiovascular disease. Side effects include nausea, drowsiness, fatigue, constipation, dry mouth. It is indicated for depression, anxiety, chronic pain, fibromyalgia, and PTSD in addition to migraine headaches. And this drug is the sumatriptan. With cluster headaches, we're also going to administer drug therapy. We may do the dihydroergotamine or methotrexate, corticosteroids, or prednisone. We can do some vasoconstricting drugs such as that sumatriptan or anticonvulsants such as gabapentin or beta-adrenergic blockers such as atenolol. Oxygen can also reduce the vasodilating compensatory response that occurs in the brain. And we can also do a rhizotomy. So question, the nurse is instructing the client on management and prevention of migraine headaches. Which of the following statements indicate the client requires further instruction? The correct answer is D. This sumatriptan is given anytime after symptoms appear. Those oral doses can be repeated in 2 hours, and a second injection can be repeated in 1 hour if we have not relieved that headache or it recurs. So transient ischemic attacks, TIAs. These are a sudden, brief episode of neurologic impairment that's caused by a temporary interruption in cerebral blood flow. In other words, they're very similar to a stroke, only they're temporary, they're transient. Causes include the atherosclerosis or arteriosclerosis, cardiac disease, and diabetes. It is a warning that a cerebrovascular accident or CVA or stroke can occur in the near future. We know that 1/3 of people that experience TIAs subsequently will develop a stroke. These clients have those temporary symptoms that are indicative of a stroke that last about an hour up to a day in length. They have temporary lightheadedness, confusion, speech disturbances, loss of vision, diplopia, variable changes in their consciousness. They may have numbness, weakness, or impaired muscle coordination, even paralysis on one side. We're going to examine these clients, auscultate that carotid artery. It may reveal a bruit, which is that abnormal sound caused by blood flowing over the rough surface of one or both of the carotid arteries. We can also do an ultrasound examination, a carotid arteriogram, a CT scan, and an MRI. Realize with the older adult that older adults may ignore the symptoms of a TIA, attributing them to part of the normal aging process. Medically, we need to control their blood pressure, encourage them to lose excess weight, stop smoking, and stop alcohol use. They need to manage their atherosclerosis and cardiac dysrhythmias, take cholesterol-lowering drugs, take prophylactic anticoagulant or antiplatelet drugs. And some of those drugs are going to include aspirin, clopidogrel, and warfarin. Aspirin and clopidogrel are both those antiplatelet drugs, and warfarin is going to be your anticoagulant. We also need to provide diabetic education. Surgically, if we notice that they have some blockages in those carotid arteries, we can do what's called a carotid endarterectomy, where they go in and surgically remove that plaque, etc. We can also do a percutaneous transluminal angioplasty and stent placement. Nurses need to remember the fast mnemonic to evaluate someone that's expected of having a stroke. Face drooping, especially on one side, arm weakness, slurred speech. It's time to call 911. Make sure that you obtain a complete history of symptoms, including their medical, drug, and allergy histories, what their weights are, capillary blood sugar, vital signs, smoking history, and a neurological examination. With carotid artery surgery, post-operatively, it's very important to do frequent neurological checks to detect paralysis, confusion, facial asymmetry, aphasia, and we need to monitor the heart rhythm. You know, we always expect things that are going to go well, but complications would include maybe some of that plaque broke loose and is creating an area of ischemia in the brain. So with the cerebrovascular accident, or CVA, brain tissue and cerebral nerve cells begin to die if they're deprived of oxygen for more than 3 to 7 minutes, which can cause irreversible changes. What's happening is we have a prolonged interruption in the flow of blood through one of the arteries that supply the brain. Risk factors include atherosclerosis and arteriosclerosis, hypertension, brain tumors, and anemia. We have two main types of stroke, and that includes ischemic stroke, which is the most common. It's caused by a thrombus or an embolus that obstructs an artery carrying blood to the brain or somewhere within the brain. Or a hemorrhagic stroke, where we have a cerebral blood vessel that ruptures and then blood is released into the brain and increases the intracranial pressure. These clients experience numbness or weakness on one side of the face, arm, or leg. They may have mental confusion, difficulty speaking or understanding, impaired walking or coordination, severe headache or unconsciousness. They may have hemiplegia, which is paralysis on one side of the body. If it's right-sided, they may have expressive aphasia, receptive aphasia, and slow, cautious behavior. With a left-sided, they may have spatial perceptual defects, poor judgment, and misjudged distances. Hemanopia is seeing only half of the visual field. So basically, you can put something in front of them and they can only see, it's like a blinder is put from their forehead all the way to their chin, and they can only see from basically it's like seeing from one eye. So they can only see half of that field. These all of these symptoms that we may see with a stroke can improve completely, partially, or not at all. We're going to diagnose with the CT scan, MRI, a transcranial Doppler, ultrasonography, or a single photon emission computed tomography, or an electroencephalogram. We can do a lumbar puncture if we suspect We can do a lumbar puncture if we suspect that there has been a subarachnoid bleeding. The cerebrospinal fluid is going to be bloody in that instance. We can also do a cerebral angiography that shows displacement or blockage of cerebral vessels. If we have someone come in with a stroke, we're usually going to automatically go ahead and initiate physical therapy, occupational therapy, and speech therapy. We're going to maybe give thrombolytics in ischemic strokes if we can do it within 3 hours of symptom onset. And remember, your thrombolytic is going to actually dissolve a clot. And if we can give it within 3 hours, we can completely reverse the stroke symptoms. Again, these clients have to meet certain requirements. No recent head injury, no recent surgeries, no recent motor vehicle accident, etc. Nurses need to use a thickening agent, keep suction machine nearby because they may have swallowing difficulties. In fact, a lot of stroke victims are actually NPO until they have been evaluated by speech therapy to determine that they are able to swallow without choking. We're also going to request small, frequent nourishment. We need to make sure that we use pressure relieving devices or a therapeutic bed if they have issues with immobility to improve skin integrity. So remember your mnemonic for recognizing a stroke. Again, additional stroke recognition. A mnemonic to remember what happens with a stroke. And this shows you how to transfer a client that has had a stroke. So question, for which type of stroke does a post-myocardial infarction client experiencing atrial fibrillation most at risk? These clients are going to be most at risk for an embolic stroke. Remember that blood is going to be static in the heart. It's not going to be pumping efficiently. It's going to be sitting there and can clot. So a client is hospitalized following a stroke, and 3 days after admission is able to converse clearly. One morning, the client's daughter runs out of the room and says, "My mother can't talk." Which response by the nurse is best? We need to assess the client and notify the RN or physician stat. A client that has had a stroke, often this stroke is what we call an evolving stroke. It doesn't stop immediately once we begin to see symptoms. It can actually continue for several days. So it's called an evolving stroke or an extending stroke, or once they've had a stroke, they're at high risk to have another one. So there's always a possibility that they are having an additional stroke.